White blood cell disorders, leukopenia and leukocytosis. Basic principles. Hematopoiesis occurs through a stepwise maturation process of CD34 positive hematopoietic stem cells in the bone marrow. These cells mature and are released into the bloodstream. A normal white blood cell count ranges between 5,000 to 10,000 per microliter of blood. A white blood cell count lower than 5,000 is called leukopenia, while a count higher than 10,000 is called leukocytosis. Abnormalities in the white blood cell count are usually due to a decrease or increase in a specific cell lineage. Leukopenia. Neutropenia refers to a decreased number of circulating neutrophils. It may occur due to drug toxicity, such as chemotherapy with alkylating agents, which damage the bone marrow stem cells and reduce white blood cell production, or due to severe infections like gram-negative sepsis, which cause increased movement of neutrophils into tissues, leading to a reduced circulating count. Treatment with granulocyte macrophage colony-stimulating factor or granulocyte colony-stimulating factor may help boost granulocyte production and reduce infection risk. Lymphopenia refers to a decreased number of circulating lymphocytes. Causes include immunodeficiency, such as DiGeorge syndrome or human immunodeficiency virus infection. High cortisol states like Cushing's syndrome or corticosteroid therapy that induce lymphocyte apoptosis. Autoimmune destruction, as in systemic lupus erythematosus, and whole-body radiation, since lymphocytes are highly sensitive to radiation and are the earliest cells to decrease. Leukocytosis. Neutrophilic leukocytosis refers to an increased number of circulating neutrophils. It occurs due to bacterial infections or tissue necrosis, which stimulate the release of immature neutrophils from the bone marrow, resulting in a left shift. These immature neutrophils are identified by decreased expression of Fc receptors, also known as CD16. Hematopoietic cluster of differentiation 34 positive stem cell. The hematopoietic cluster of differentiation 34 positive stem cell gives rise to the myeloid stem cell and the lymphoid stem cell. Myeloid stem cell. From the myeloid stem cell arises the erythroblast, which matures into red blood cells. The myeloblast develops into neutrophils, basophils, and eosinophils. The monoblast gives rise to monocytes, and the megakaryoblast forms megakaryocytes, which further produce platelets. Lymphoid stem cell. From the lymphoid stem cell arises the B lymphoblast, which matures into naive B cells and then differentiates into plasma cells. The T lymphoblast matures into naive T cells, which further develop into cluster of differentiation 8 positive T cells and cluster of differentiation 4 positive T cells. A high cortisol state may also cause neutrophilic leukocytosis by impairing leukocyte adhesion, leading to the release of marginated neutrophils into circulation. Monocytosis refers to an increased number of circulating monocytes and is associated with chronic inflammatory states such as autoimmune diseases, persistent infections, and certain malignancies. Eosinophilia refers to an increased number of circulating eosinophils and occurs in allergic reactions, parasitic infections, and Hodgkin lymphoma. The increase is driven by elevated levels of eosinophil chemotactic factor. Basophilia refers to an increased number of circulating basophils and is classically seen in chronic myeloid leukemia. Lymphocytic leukocytosis refers to an increased number of circulating lymphocytes. It is commonly caused by viral infections, during which T lymphocytes undergo hyperplasia in response to infected cells. Another cause is Bordetella pertussis infection, in which the bacteria produce a lymphocytosis-promoting factor that prevents lymphocytes from leaving the blood to enter lymphoid tissues. Infectious mononucleosis. Infectious mononucleosis is most commonly caused by Epstein-Barr virus infection and is characterized by lymphocytic leukocytosis composed of reactive CD8, positive T cells. Cytomegalovirus infection can also cause a similar presentation. Epstein-Barr virus is transmitted through saliva, often referred to as the kissing disease, and commonly affects teenagers. Epstein-Barr virus primarily infects the oropharynx, leading to pharyngitis, the liver, causing hepatitis with hepatomegaly and elevated liver enzymes, and B lymphocytes. The immune response is mediated by activated CD8 positive T cells, which lead to generalized lymphadenopathy due to T-cell hyperplasia in the paracortex of lymph nodes, and splenomegaly due to hyperplasia of the periarterial lymphatic sheath in the spleen. Peripheral blood shows a high white blood cell count with atypical reactive lymphocytes. The monospot test is used for screening and detects immunoglobulin M antibodies that cross-react with horse or sheep red blood cells, also known as heterophile antibodies. The test typically becomes positive within 1 week of infection. A negative result suggests cytomegalovirus as an alternative cause. Definitive diagnosis is made by serologic testing for Epstein-Barr viral capsid antigen. Complications of infectious mononucleosis include an increased risk of splenic rupture, for which patients are advised to avoid contact sports for about 1 year. Exposure to ampicillin during infection may cause a rash. The Epstein-Barr virus remains dormant in B cells and may reactivate, leading to recurrence or development of B-cell lymphomas, especially in cases of immunodeficiency, such as human immunodeficiency virus infection. Acute leukemia. Basic principles. Acute leukemia is a neoplastic proliferation of immature precursor cells, known as blasts, and is defined by the accumulation of more than 20% blasts in the bone marrow. The excessive accumulation of blasts crowds out normal hematopoietic cells, leading to an acute clinical presentation characterized by anemia causing fatigue, thrombocytopenia causing bleeding, and neutropenia predisposing to infections. The blasts frequently enter the bloodstream, resulting in a markedly elevated white blood cell count. Morphologically, blasts are large, immature cells with open chromatin and prominent punched-out nucleoli. Acute leukemia is classified into acute lymphoblastic leukemia and acute myeloid leukemia based on the lineage and phenotype of the blasts. Acute lymphoblastic leukemia. Acute lymphoblastic leukemia is a neoplastic accumulation of lymphoblasts greater than 20% in the bone marrow. The lymphoblasts are identified by positive nuclear staining for terminal deoxynucleotidal transferase, a DNA polymerase found only in the nuclei of lymphoid precursors. This enzyme is absent in myeloid blasts and mature lymphocytes. Acute lymphoblastic leukemia most commonly arises in children and is associated with Down syndrome, typically developing after the age of 5 years. It is subclassified into B-cell acute lymphoblastic leukemia and T-cell acute lymphoblastic leukemia based on surface antigen expression. B-cell acute lymphoblastic leukemia is the most common form and is characterized by lymphoblasts that express terminal deoxynucleotidal transferase along with surface markers CD10, CD19, and CD20. It shows an excellent response to chemotherapy, although prophylactic treatment of the scrotum and cerebrospinal fluid is required due to the potential for leukemic infiltration. Prognosis depends on specific cytogenetic abnormalities. The translocation T1221 is associated with a good prognosis and is most commonly seen in children, while the translocation T922, also known as the Philadelphia chromosome, confers a poor prognosis and is more common in adults. T-cell acute lymphoblastic leukemia is characterized by lymphoblasts that express terminal deoxynucleotidal transferase and surface markers ranging from CD2 to CD8, including CD3, CD4, and CD7, but not CD10. It usually presents in teenagers as a mediastinal or thymic mass, and is therefore often referred to as acute lymphoblastic lymphoma due to its mass-forming nature. Acute myeloid leukemia. Acute myeloid leukemia is a neoplastic accumulation of myeloblasts greater than 20% in the bone marrow. Myeloblasts are identified by positive cytoplasmic staining for myeloperoxidase, and crystal aggregates of this enzyme may be seen as hour rods. The disease most commonly arises in older adults with an average age between 50 and 60 years. Acute myeloid leukemia is subclassified based on cytogenetic abnormalities, the lineage of myeloblasts, and specific surface markers. A high-yield subtype is acute promyelocytic leukemia, which is characterized by the translocation T1517 that involves the retinoic acid receptor gene on chromosome 17 and the promyelocytic leukemia gene on chromosome 15. This translocation disrupts the normal function of the retinoic acid receptor, blocking myeloid maturation and causing the accumulation of abnormal promyelocytes. These abnormal cells contain numerous primary granules that increase the risk for disseminated intravascular coagulation. Treatment involves all-trans-retinoic acid, a vitamin A derivative, which binds to the altered receptor and induces the maturation and subsequent death of the blasts. Another subtype is acute monocytic leukemia, which involves proliferation of monoblasts that typically lack myeloperoxidase. The blasts characteristically infiltrate the gums, causing gingival hypertrophy. Acute megakaryoblast leukemia involves proliferation of megakaryoblasts that also lack myeloperoxidase. It is associated with Down syndrome and usually arises before the age of 5 years. Acute myeloid leukemia may also arise from pre-existing myelodysplastic syndromes, particularly in individuals with a history of exposure to alkylating agents or radiation therapy. Myelodysplastic syndromes typically present with cytopenias, a hypercellular bone marrow with abnormal cellular maturation, and increased but less than 20% blasts. Most patients with myelodysplastic syndromes die from infection or bleeding, although some progress to acute leukemia. Chronic leukemia. Basic principles. Chronic leukemia is a neoplastic proliferation of mature, circulating lymphocytes and is characterized by an elevated white blood cell count. The disease usually has an insidious onset and primarily affects older adults. Chronic lymphocytic leukemia. Chronic lymphocytic leukemia is a neoplastic proliferation of naive B lymphocytes that co-express cluster of differentiation 5 and cluster of differentiation 20 and is the most common leukemia overall. The peripheral blood smear shows increased numbers of lymphocytes along with the presence of smudge cells. When the lymph nodes are involved, the condition manifests as generalized lymphadenopathy and is referred to as small lymphocytic lymphoma. Complications of chronic lymphocytic leukemia include hypogammaglobulinemia, in which decreased immunoglobulin production predisposes to infections that are the most common cause of death, autoimmune hemolytic anemia, and transformation to diffuse large B-cell lymphoma, known as Richter transformation, which presents clinically as a rapidly enlarging lymph node or spleen. Hairy cell leukemia. Hairy cell leukemia is a neoplastic proliferation of mature B lymphocytes that display characteristic cytoplasmic projections, giving a hairy appearance. The neoplastic cells are positive for tartrate-resistant acid phosphatase. Clinical features include splenomegaly due to accumulation of hairy cells in the red pulp and a dry tap on bone marrow aspiration due to extensive marrow fibrosis. Lymphadenopathy is typically absent. The disease responds excellently to treatment with 2-chlorodeoxyadenosine, also known as cladribine, which is an adenosine deaminase inhibitor that leads to toxic accumulation of adenosine within neoplastic B lymphocytes, causing their death. Adult T-cell leukemia or lymphoma. Adult T-cell leukemia or lymphoma is a neoplastic proliferation of mature cluster of differentiation 4-positive T lymphocytes. It is associated with infection by human T lymphotropic virus type 1 and occurs most commonly in Japan and the Caribbean. The clinical features include a skin rash due to infiltration of malignant T cells, generalized lymphadenopathy with hepatosplenomegaly, and lytic or punched-out bone lesions accompanied by hypercalcemia. MYCOSIS fungoides. MYCOSIS fungoides is a neoplastic proliferation of mature cluster of differentiation 4-positive T lymphocytes that infiltrate the skin, producing localized lesions that manifest as a skin rash, plaques, or nodules. Aggregates of neoplastic T cells within the epidermis are referred to as pottery or microabscesses. The neoplastic cells may eventually spread to the bloodstream, resulting in Sézary syndrome. In this condition, characteristic lymphocytes with cerebriform or folded nuclei, known as Sézary cells, are observed on the peripheral blood smear. Myeloproliferative disorders. Basic principles. Myeloproliferative disorders are neoplastic proliferations of mature cells derived from the myeloid lineage and are typically diseases of late adulthood, with an average onset age between 50 and 60 years. These disorders result in an increased white blood cell count and a hypercellular bone marrow. The cells of all myeloid lineages are increased, and classification is based on the dominant myeloid cell type that is proliferating. Complications of myeloproliferative disorders include an increased risk of hyperuricemia and gout due to the high turnover of cells, as well as possible progression to bone marrow fibrosis or transformation into acute leukemia. Chronic myeloid leukemia. Chronic myeloid leukemia is a neoplastic proliferation of mature myeloid cells, particularly granulocytes and their precursors, with basophils characteristically increased. The disease is driven by a translocation between chromosome 9 and 22, known as the Philadelphia chromosome, which produces a BCR-ABL fusion protein that exhibits increased tyrosine kinase activity. The first-line treatment is imatinib, a tyrosine kinase inhibitor. Splenomegaly is a common feature, and an enlarging spleen indicates an accelerated phase of the disease, which often precedes transformation to acute leukemia. Transformation may occur to acute myeloid leukemia in 2/3 of cases or to acute lymphoblastic leukemia in 1/3 of cases, as the mutation occurs in a pluripotent stem cell. Chronic myeloid leukemia is differentiated from a leukemoid reaction, which is a reactive neutrophilic leukocytosis, by a negative leukocyte alkaline phosphatase stain, the presence of increased basophils, and the presence of the T9/22 translocation, all of which are absent in a leukemoid reaction. Polycythemia vera. Polycythemia vera is a neoplastic proliferation of mature myeloid cells, with a predominance of red blood cells, although granulocytes and platelets are also increased. It is associated with a JAK2 kinase mutation. The clinical features are primarily due to hyperviscosity of the blood and include blurry vision and headache. An increased risk of venous thrombosis involving sites, such as the hepatic vein, portal vein, or dural sinus, a flushed facial appearance due to congestion known as plethora, and itching after bathing, which results from histamine release from increased mast cells. The primary treatment is phlebotomy, while hydroxyurea serves as second-line therapy. Without treatment, death usually occurs within 1 year. Polycythemia vera must be distinguished from reactive polycythemia. In polycythemia vera, erythropoietin levels are decreased and arterial oxygen saturation is normal. In reactive polycythemia, caused by high altitude or chronic lung disease, arterial oxygen saturation is decreased and erythropoietin is elevated. In reactive polycythemia, due to ectopic erythropoietin production from renal cell carcinoma, erythropoietin is elevated while arterial oxygen saturation remains normal. Essential thrombocythemia. Essential thrombocythemia is a neoplastic proliferation of mature myeloid cells, particularly platelets, although red blood cells and granulocytes are also increased. The condition is associated with a JAK2 kinase mutation. Clinical manifestations are primarily related to an increased risk of bleeding and thrombosis. The disease rarely progresses to bone marrow fibrosis or acute leukemia, and there is no significant risk of hyperuricemia or gout. Myelofibrosis. Myelofibrosis is a neoplastic proliferation of mature myeloid cells, primarily megakaryocytes, and approximately 50% of cases are associated with a JAK2 kinase mutation. The megakaryocytes produce excess platelet-derived growth factor, leading to bone marrow fibrosis. Clinical features include splenomegaly due to extramedullary hematopoiesis, a leukoerythroblastic blood smear characterized by teardrop-shaped red blood cells, nucleated red blood cells, and immature granulocytes, as well as an increased risk of infection, thrombosis, and bleeding. Lymphadenopathy. Basic principles. Lymphadenopathy refers to the enlargement of lymph nodes. Painful lymphadenopathy is most commonly observed in lymph nodes that are draining an area affected by an acute infection, a condition known as acute lymphadenitis. In contrast, painless lymphadenopathy may occur in association with chronic inflammation, termed chronic lymphadenitis, as well as with metastatic carcinoma or lymphoma. In cases of inflammation, lymph node enlargement results from hyperplasia of specific regions within the lymph node. Follicular hyperplasia, which occurs in the B-cell region, is commonly seen in conditions such as rheumatoid arthritis and in the early stages of human immunodeficiency virus infection. Paracortex hyperplasia, which involves the T-cell region, typically arises in response to viral infections, such as infectious mononucleosis. Hyperplasia of sinus histiocytes is observed in lymph nodes that are draining tissues affected by cancer. Lymphoma. Basic principles. Lymphoma refers to a neoplastic proliferation of lymphoid cells that form a mass, which may arise either in a lymph node or in extranodal tissue. It is broadly divided into non-Hodgkin lymphoma and Hodgkin lymphoma. Non-Hodgkin lymphoma accounts for approximately 60% of cases, while Hodgkin lymphoma represents around 40%. Non-Hodgkin lymphoma is further classified according to the type of cell involved, whether B cell or T cell, the size of the cell, the pattern of cell growth, the expression of specific surface markers, and the presence of cytogenetic translocations. Small B cell types include follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, and small lymphocytic lymphoma, which represents chronic lymphocytic leukemia cells involving tissue. Intermediate-size B-cell lymphomas include Burkitt lymphoma, while large B-cell lymphomas are represented by diffuse large B-cell lymphoma. In general comparison, non-Hodgkin lymphoma is more frequent, composed predominantly of malignant lymphoid cells, and tends to spread diffusely with possible extranodal involvement. Hodgkin lymphoma, on the other hand, is defined by the presence of Reed-Sternberg cells within a background of predominantly reactive inflammatory and fibrotic cells. Non-Hodgkin lymphoma usually presents with painless lymphadenopathy in late adulthood, whereas Hodgkin lymphoma often arises in young adults, sometimes associated with these symptoms such as fever, night sweats, and weight loss. The spread of non-Hodgkin lymphoma is diffuse, while Hodgkin lymphoma spreads contiguously. Staging is of limited importance in non-Hodgkin lymphoma, but is crucial in Hodgkin lymphoma, where radiation therapy remains the mainstay of treatment. A leukemic phase can occur in non-Hodgkin lymphoma, but not in Hodgkin lymphoma. Follicular lymphoma. Follicular lymphoma is a neoplastic proliferation of small B cells that express CD20 and form follicle-like nodules. It typically presents in late adulthood with painless lymphadenopathy. The disease is driven by the translocation T14-18, in which the BCL2 gene on chromosome 18 translocates to the immunoglobulin heavy chain locus on chromosome 14, resulting in overexpression of the BCL2 protein that inhibits apoptosis. Treatment is reserved for symptomatic patients and involves low-dose chemotherapy or rituximab, a monoclonal antibody against CD20. A significant complication is transformation into diffuse large B-cell lymphoma, which presents as an enlarging lymph node. Follicular lymphoma can be distinguished from reactive follicular hyperplasia by the disruption of normal lymph node architecture, absence of tingible body macrophages in germinal centers, expression of BCL2 within follicles, and monoclonality, whereas reactive follicular hyperplasia is polyclonal. Mantle cell lymphoma. Mantle cell lymphoma is a neoplastic proliferation of small B cells that express CD20 and expand the mantle zone. It typically occurs in late adulthood and presents with painless lymphadenopathy. The disease is driven by the translocation T11-14, in which the cyclin D1 gene on chromosome 11 translocates to the immunoglobulin heavy chain locus on chromosome 14, leading to overexpression of cyclin D1. This overexpression promotes the transition from the G1 to the S phase of the cell cycle, facilitating uncontrolled cellular proliferation. Marginal zone lymphoma. Marginal zone lymphoma is a neoplastic proliferation of small B cells that express CD20 and expand the marginal zone. It is associated with chronic inflammatory conditions such as Hashimoto thyroiditis, Sjogren's syndrome, and Helicobacter pylori, associated gastritis. The marginal zone normally develops from post-germinal center B cells. When this lymphoma arises in mucosal tissues, it is referred to as mucosa-associated lymphoid tissue lymphoma, or MYELOMA. Gastric MYELOMA can regress with appropriate eradication of Helicobacter pylori infection. Burkitt lymphoma. Burkitt lymphoma is a neoplastic proliferation of intermediate-sized B cells that express CD20 and is associated with Epstein-Barr virus infection. It classically presents as an extranodal mass in children or young adults. The African or endemic form most commonly involves the jaw, while the sporadic form usually involves the abdomen. It is driven by translocations involving the c-MYC gene on chromosome 8, most commonly the T8-14 translocation, which moves the c-MYC gene to the immunoglobulin heavy chain locus on chromosome 14. This leads to overexpression of the c-MYC oncogene and promotes uncontrolled cellular growth. Microscopically, Burkitt lymphoma is characterized by a high mitotic index and a distinctive starry sky appearance. Diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is a neoplastic proliferation of large B cells that express CD20 and grow diffusely in sheets, replacing the normal lymph node architecture. It is the most common form of non-Hodgkin lymphoma and is clinically aggressive with a high-grade course. It may arise de novo or result from the transformation of a low-grade lymphoma, such as follicular lymphoma. The disease usually presents in late adulthood with an enlarging lymph node or an extranodal mass. Hodgkin lymphoma. Basic principles. Hodgkin lymphoma is a neoplastic proliferation of Reed-Sternberg cells, which are large B lymphocytes characterized by multilobe nuclei and prominent nucleoli, giving them an appearance often described as allied nuclei. These cells are classically positive for the surface markers CD15 and CD30. Reed-Sternberg cells secrete a variety of cytokines that play an important role in the clinical and pathological features of the disease. The release of these cytokines can occasionally result in systemic B symptoms, which include fever, chills, and night sweats. They also attract reactive lymphocytes, plasma cells, macrophages, and eosinophils to the tumor microenvironment and may stimulate the development of fibrosis within the affected lymph node. The majority of the tumor mass in Hodgkin lymphoma is composed not of the neoplastic Reed-Sternberg cells themselves, but of these reactive inflammatory cells. The composition of these reactive cells forms the basis for the classification of the different subtypes of Hodgkin lymphoma, which include nodular sclerosis, lymphocyte-rich, mixed cellularity, and lymphocyte-depleted types. Nodular sclerosis type. Nodular sclerosis is the most common subtype of Hodgkin lymphoma, accounting for approximately 70% of all cases. It typically presents as an enlarging cervical or mediastinal lymph node in a young adult, more frequently in females. Histologically, the affected lymph node is divided by thick bands of collagenous sclerosis. Within these sclerotic nodules, Reed-Sternberg cells can be seen lying in characteristic open, lake-like spaces, where they are referred to as lacunar cells. Other subtypes. The lymphocyte-rich subtype is associated with the best overall prognosis among the forms of Hodgkin lymphoma. The mixed cellularity subtype often contains abundant eosinophils, a finding explained by the production of interleukin-5 by Reed-Sternberg cells, which attracts eosinophils into the tumor environment. The lymphocyte-depleted subtype is the most aggressive variant and is typically seen in elderly individuals or those who are positive for human immunodeficiency virus infection. Plasma cell disorders. Multiple myeloma. Multiple myeloma is a malignant proliferation of plasma cells within the bone marrow and represents the most common primary malignancy of bone, although metastatic cancer remains the most frequent overall cause of malignant bone lesions. High levels of interleukin-6 may be present in some cases, which stimulate plasma cell growth and promote the production of immunoglobulins. The clinical features of multiple myeloma include bone pain associated with hypercalcemia. Neoplastic plasma cells activate the receptor activator of nuclear factor kappa B on osteoclasts, leading to bone resorption and destruction. Radiographic studies often reveal multiple lytic, punched-out skeletal lesions, especially within the vertebrae and skull, resulting in an increased risk of pathologic fractures. Serum protein levels are elevated due to the excessive production of monoclonal immunoglobulins by the neoplastic plasma cells. On serum protein electrophoresis, a characteristic monoclonal spike is observed, most commonly caused by immunoglobulin G or immunoglobulin A. Because these monoclonal antibodies lack antigenic diversity, patients are highly susceptible to recurrent infections, which represent the leading cause of death in multiple myeloma. Peripheral blood smears show rouleau's formation of red blood cells, which occurs because the increased serum protein concentration reduces the electrostatic repulsion between erythrocytes, causing them to stack together in linear chains. Free light chains produced by the neoplastic plasma cells circulate in the blood and may deposit in tissues, leading to primary amyloidosis of the AL type. These light chains are excreted in the urine as Bence-Jones proteins, and their accumulation in renal tubules can cause tubular damage and contribute to renal failure, often referred to as myeloma kidney. Monoclonal gammopathy of undetermined significance. Monoclonal gammopathy of undetermined significance is characterized by an increased serum protein level with a monoclonal spike observed on serum protein electrophoresis, but without the other clinical or laboratory features of multiple myeloma. Patients with this condition do not exhibit lytic bone lesions, hypercalcemia, amyloid deposition, or Bence-Jones proteinuria. It is commonly found in the elderly population and is present in approximately 5% of individuals over 70 years of age. Each year, around 1% of patients with monoclonal gammopathy of undetermined significance progress to develop multiple myeloma. Waldenström macroglobulinemia. Waldenström macroglobulinemia is a B-cell lymphoma characterized by the production of monoclonal immunoglobulin M. Unlike multiple myeloma, it does not produce lytic bone lesions. The clinical manifestations include generalized lymphadenopathy and an elevated serum protein level with a monoclonal spike composed of immunoglobulin M. Because immunoglobulin M is a large pentameric molecule, its excessive production results in serum hyperviscosity, which can lead to visual and neurological disturbances such as retinal hemorrhage or stroke. The increased viscosity of the blood also interferes with normal platelet aggregation, predisposing to bleeding tendencies. Acute complications related to hyperviscosity in Waldenström macroglobulinemia are managed with plasmapheresis, a procedure that removes the excess immunoglobulin M from the circulation. Langerhans cell histiocytosis. Basic principles. Langerhans cells are specialized dendritic cells that are primarily located in the skin. They originate from bone marrow monocytes and play an important role in the immune system by presenting antigens to naive T lymphocytes. Langerhans cell histiocytosis refers to a neoplastic proliferation of these cells. On electron microscopy, the neoplastic cells characteristically display Burbeck granules, which have a tennis racket-shaped appearance. Immunohistochemical staining reveals that the cells are positive for cluster of differentiation 1A and S100 protein. Letter-Siwe disease. LEUKOPENIA disease represents a malignant proliferation of Langerhans cells. It typically presents in infancy, usually before 2 years of age, with a diffuse skin rash and multiple cystic skeletal defects. The disease often involves multiple organs and follows a rapidly progressive and fatal course if untreated. Eosinophilic granuloma. Eosinophilic granuloma is a benign form of Langerhans cell proliferation that occurs within bone. It classically presents in adolescence with pathologic fractures, and unlike the malignant forms, it does not involve the skin. Histologic examination of the lesion shows Langerhans cells mixed with numerous inflammatory cells, particularly eosinophils, which contribute to the granulomatous appearance. Hand-Schüller-Christian disease. Hand-Schüller-Christian disease is a malignant proliferation of Langerhans cells that typically occurs in childhood. It presents with a characteristic triad consisting of a chronic scalp rash, lytic skull bone defects, diabetes insipidus due to pituitary involvement, and exophthalmos resulting from infiltration of the orbit by neoplastic cells.